Hello, I'm Mary Beth Marsden, and welcome to GBMC's Ask the Oncology Expert. Today, we are happy to have with us Dr. Kruti Patel, who is a radiation oncologist at Sandra and Malcolm Berman Cancer Institute at GBMC. Dr. Patel, thank you so much for being with us.
Good afternoon. Thanks for having me.
You know, I think whenever we talk with someone we know, let's say, who is being treated for cancer, we have like two questions always. Are you getting chemo and are you getting radiation, right? I mean, those are the two sort of standard bearers for treatment.
Absolutely. It's definitely one of the big components of treatment.
So in broad terms, what determines if a patient, I'm sure it's individual, obviously, with every patient, but what are some of the determining factors that will decide if someone needs to, in fact, have radiation therapy?
That's a great question. So radiation has a lot of different roles within cancer treatment. So first off, most generally, it depends on what type of cancer the patient has. And that will determine whether radiation is sort of a primary modality of treatment or if it's going to be something that's considered after surgery or even before. So determinants of whether or not you would need radiation, let's say in breast cancer, is often mostly based on what is found at the time of surgery on the final pathology, coupling in factors such as the patient's age and overall health. And how they presented, but oftentimes it's after what we see after surgery or what they presented with up front in terms of their stage. So that's just one example.
I think there's some old misconceptions about radiation. I used to feel that that chemo was the first line of defense or attack, and then radiation came in second. And if you had radiation with chemo, there was a more aggressive approach to treating your cancer. But sometimes doesn't necessarily mean that, right?
That's correct. So again, there's just so many different combinations of how our treatments are done. Sometimes radiation's done alone for depending on the disease that it is and how effective radiation can be in that setting. Sometimes chemotherapy is given concurrently to sort of make the radiation work even better. However, with newer techniques of radiation coming out that are more focused and effective on their own, chemotherapy sometimes is not given at the same time, and it's just radiation. And it's not necessarily taking a step back, but it's just that the radiation has sort of been amped up.
Okay, so I want to make sure, because so many people are tuning in right now who have asked questions and they want to have some answers to those questions, or maybe they asked them thinking those questions would help someone else as well. And then we want to talk about sort of the future of radiation, because I know that's a passion for you, and you're going to be kind of even studying that further in the coming months. But so the first questions, they seem specific, but also they could appeal to a wide variety of people. And I'm just going to kind of run down the list, if that's okay. So we're going to start with a disease, oligometastatic disease. If you could just tell us what that is and the treatment for that.
Absolutely. I think that's a great point. So oligometastatic cancer is patients who either have been diagnosed or at some point their cancer has progressed to the point where it's no longer confined to the organ in which it started. So traditionally, what has sort of been known as stage 4 cancer, a cancer that has spread elsewhere. And certainly, as time goes on, we are recognizing and seeing more and more data to support that. The number of sites that the cancer is spread to is very important, and it definitely makes a difference in terms of the prognosis for a patient. So oligometastatic, and there's varying definitions for this, but basically saying that a patient has limited disease outside of where the cancer initiated. So they may have metastases to, say, 3 spots outside of where things started. And so it's an important distinction because we are sort of handling and treating and looking at these patients differently because they tend to do better. So we are trying to be more aggressive with their treatment, and rather than just focusing on systemic or everywhere treatment as had been done more commonly in the past, where we used to say, well, if the disease was metastatic, it is treatable, but not necessarily curable. And that's changing too. We are seeing patients and also literature being published about series of certain cancers in which there could be 1 or 2 metastases, and there's still a chance for long-term cure.
Another question, what is sBRT?
So sBRT stands for stereotactic body radiation therapy. It's a type of radiation in which we administer a high dose, but that's really, really focused to a defined small, typically small target. And it's often ablative or able to completely get rid of tumor in that location. We commonly implement this type of radiation for early stage lung cancers, often in patients who either cannot or do not want to undergo surgery or removal of part of their lung. And it is a very effective regimen. Its success rate is upwards of 90%. And then just on the heels of the question of oligometastasis, sBRT has a really big role for this patient population as well, because when we're seeing just a couple of spots and foci outside of where the disease has initiated, we can target some of those other areas with sBRT to sort of prolong the patient's course of being free of having active disease, and also controlling symptoms if they have that related to it. So it's a very focused high dose modality that's effective, that we can use in a range of locations, whether it's lung, bone, even certain lymph nodes. But location is an important piece of how and when we use this type of radiation.
Is radiation treatment an option in cancers such as ovarian cancer?
So radiation is not part of the upfront management typically of ovarian cancer. But again, with thinking about oligometastatic disease, it does come into play. I think there is an ongoing phase 2 trial right now looking at treating ovarian cancers that either have just a small focus of disease left over after standard treatment, or recurrence again in a small area focused after standard treatment, and seeing if that would benefit slowing down progression. But it can be, and I've certainly used it in a small number of patients, but it can have a role, maybe not as widely as other types of cancers.
We've had, and speaking of other types of cancers, we've had a number of, understandably, breast cancer questions. One question that just came in live, is radiation the first step to treat triple negative breast cancer, which of course is a very aggressive form of breast cancer?
Sure. So radiation typically is delivered after surgery for breast cancers. And sometimes if chemotherapy is needed, which it many times is for triple negative cases, it is delivered thereafter. So it comes usually after and not as the first step.
If a patient receives radiation treatment in one breast, then the cancer recurs in the other breast, is radiation treatment still an option?
That's a great question, because they are different organs and they do behave differently. And the answer is absolutely yes. I've certainly treated patients who were cured of their cancer in one breast, doing well, and then some years down the road developed another cancer in the opposite breast. I've also treated more than a handful, quite a few patients who actually had breast cancer in both breasts at the same time.
What are the long-term side effects from radiation therapy, such as breast tenderness, numbness in the limbs, and inflammation in the body in general?
So side effects of radiation are typically really related to the location of the body that we're treating. So if we're talking about breast, potential long-term toxicities could include lymphedema, which is also a potential side effect of the surgery that's done. So swelling of the arm that's associated with the breast that we treat. Also swelling of the breast in itself is possible. And then the things that lymphedema can cause in terms of functional outcomes. So it could be pain or numbness really from the swelling, not really from nerve issues. So that's something that can happen if we're talking about a patient who's had very limited surgery in their axilla and we're not fully treating lymph node areas, the risk is often really low in the single digits range. So it's not something that we see commonly, but sometimes patients need a dissection of their axilla, so more lymph nodes taken out surgically, followed by the need for radiation to that area. And then the risk is much higher, on the order of 15%, or even more, looking at other individual risk factors. So there's sort of a range. So that is one of the long-term side effects.
I'm sure.
I'm sorry, go ahead.
No, go ahead. It just strikes me that I'm sure with every single patient, it's constantly weighing out the type of radiation treatment, if it's needed, what the potential side effects are, and weighing out sort of how you can come with the best outcome.
Yes, and that's exactly right. That is what your radiation oncologist is sort of doing and looking at and evaluating is, what's your risk of having either this disease coming back and the problems that could stem from that? And then what are your risks of having a side effect develop from radiation? And do the benefits of the treatment greatly outweigh the risks or not? And so that's exactly what goes into determining whether or not I recommend radiation for a specific person. And so, yes, it's very much so a balance of that, looking at all of the different side effects that the treatment could potentially cause.
And I think before I cut you off, you were going to sort of delve into some other side effects from radiation treatment, maybe in other parts of the body. We did get a general question about that. I'm sure it's different for everything you're treating, but what are some of the general sort of overreaching side effects that many people can expect to see with radiation treatment?
So if we're talking during treatment or the short term, fatigue is one that can be present, and it can affect different people differently, but that can have some effect on people throughout treatment. Skin changes for many patients, but not all again. Mostly when we treat targets that are sort of in the center of the body, not so superficial, like lung cancers, for example, or even certain GI cancers, we don't really see any skin changes at all. But in the head and neck region, the breast, we certainly do see some skin changes that happen, whether it's color changes, itching, tenderness, and then long-term scarring or fibrosis, or just sort of a change in the appearance and feel of the skin. So those are a couple of things that can happen. But yes, very specific based on what part of the body that we're treating, also the technique that we're using, and of course the dose. These are all important factors.
Yes. Someone just asked, and you may need more information, but their question is, if you have breast cancer that's, I guess, gone to the liver and we're treated with radiation, is pain and numbness in the side normal?
So that's a really specific question.
Yes.
And so we would sort of need to evaluate that. But I would say it's not normal. It sounds like someone's describing focal treatment for and maybe an oligo progression or oligometastasis in the liver, whether that was with sBRT or liver-directed therapy. And it is possible, but not necessarily an expected side effect. The location in the liver is a pretty big organ, also matters. So it's possible, but not necessarily a common or expected outcome.
How long does the radiation treatment remain in the body, and can it prevent cancer from spreading to the other areas in the body?
So that's a good question. I often get that, like, how long is the radiation inside of me? The radiation is never quite in the person. So the radiation has its effect on the patient. And this is mostly talking about when we're treating with external beam radiation, different from when, let's say, radioactive seeds are being implanted into the prostate gland. So that's a different scenario in which the person is emitting radiation and is radioactive. But for external beam, when you're coming in for daily treatments and sort of laying down under the machine, at no point are you radioactive. So the radiation's not really in you, the effects are on you. In terms of how long do the effects go on? Well, against the cancer, we say, that happens during treatment, but for several weeks thereafter. So for some kinds of cancers, we will often recommend that there's a CT or PET scan done afterwards to see the response of the cancer to the radiation treatment. And patients will often question, well, why do I have to wait 3 months? And part of this is because the radiation doesn't stop working against the cancer the day you have your last treatment. Its impact and effect on the cancer continues over several weeks. And so there's that piece of it. And then on normal tissues, the impact and effect can last a long time, which is why we talk about certain long-term or permanent side effects that can happen from radiation.
What is proton therapy and how does it differ from standard radiation treatment specifically for breast and or gynecological cancers?
So proton therapy is a type of radiation treatment. It's a particle versus using photons, which is more used widely, and that's more, I guess, standard. The big difference in terms of how they work is with photons or standard X-rays, there's what we call entrance dose as well as exit dose. So on the way to the target and even after the target, there is some dose that's administered. It's not all entirely on the target without being deposited in other areas. That's why there are some side effects. With protons, you still have entrance dose, but then much of the dose is deposited at the target, and there is very little to no exit dose. So it's sort of different in terms of how it gives off its dose. With use in terms of breast and gynecologic cancers, I know there's an ongoing trial looking at that and sort of comparing. It's still an area in radiation therapy that we're sort of studying to see whether there's a benefit and then which particular patient population there may be more of a benefit to using protons over photons. So it's something that's sort of being looked at and studied in terms of practicality. I hope that answers that.
Dr. Patel, I know that cancer care and radiation therapy is ever evolving, and you're very passionate about the future and what that holds. You're doing a fellowship soon, I believe. Talk about that and where you hope treatment is going and changing for the better.
Absolutely. So the fellowship that I'm actually pursuing is in integrative oncology. So it's not specific to radiation oncology, but it is specific to oncology. It's through the University of Michigan, and it's backed by the NCI. So the participants or the fellows this year come from different, we have physicians, we have radiation oncologists, people from medical oncology, there's physicians, there's nurses. So it's kind of a wide range. And so it's just incorporating sort of and trying to integrate better ways and different ways and techniques outside of allopathic medicine and even outside of sort of this hemisphere and kind of combining more approaches in an evidence-based manner. So, using modalities that have research and literature to sort of support their use alongside with the traditional treatments that we recommend so that the patient experience, quality of life can be better. So I think that's an important place that oncology is evolving as a field. We certainly look at that more and more in terms of our treatment regimens when we're picking that, especially for palliative patients. Choosing sometimes a fewer number of treatments if we know that the outcome is going to be just as good for that type of person in order to minimize the visits that they're having, for example. So I think there is an evolution that's really focused more on the patient experience and quality of life and not just quantity, and that being for while they're going through treatment, but also long-term. And with long-term quality of life, there's definitely been advances and changes in radiation oncology with regards to our technology and technique. For example, we routinely use deep inspiratory breath hold as a technique for certain breast cancer patients, especially when we're treating the left side, to sort of minimize the dose to the heart because we're worried about what impact this radiation that's so helpful and risk reducing right now could have on that patient's heart years to decades down the road, because we want them to be healthy and enjoying a full life at that time point. As we say to patients, we want to get rid of this problem for you. We want you to cure it, but it's so that you can go on to have meaningful life. So I think, that's an example of sort of how we're evolving to keep that in mind.
It seems like when it comes to the Berman Cancer Center that the patient-centered approach is very important to everyone who works there.
Absolutely. And I will say that I hear that from patients time and again, that they have just been impressed and just feel so cared for by every person that they've met here. And it's a point of pride that now I expect that. I expect that from everyone, whether it's within my department or all of the wonderful colleagues that we have here in the other disciplines that we work with. It is absolutely a focus because it's really the reason why we come, why we show up, and why we're here. It's to take care of people. And so that is definitely at the center while we're working through these difficult conversations and difficult treatments and decisions. But we really, really work hard to make sure that people feel like they're cared for.
Yeah, and obviously the community reaches out back to you often. And for those who may be just experiencing the Berman Cancer Institute, or they've heard about it and they're glad it's in their backyard, how can they support? How can the community support what you do?
So within radiation oncology, it's a very technology heavy and technology driven field. And so we've made lots of advances, and technology can also be quite pricey. So that is one way in which that can be helpful in terms of sort of being very up to date and having all the tools at our disposal that we can use to provide the best care possible. Also, cancer care in general can be quite a financial burden on a lot of our patients. A lot of radiation regimens require daily treatments Monday through Friday, 5 days a week for several weeks. So even something like transportation isn't so simple or readily accessible for everyone. And we're very grateful to be able to help out with those costs and, provide patients a safe and reliable way of getting here for their daily treatments. So that's definitely a way in which we can help. Nutrition is really important through treatments. And there are patients who have to rely on using nutritional supplements, which also can be an expense that adds up quickly. And it is very, very nice when we're able to sort of help patients with that and help provide them with that angle of care that they need very much so to get through their treatments.
Dr. Kruti Patel, thank you so much for being with us and talking about radiation and oncology. We really appreciate it. There's a lot to take in, and it was fascinating. So thank you, and good luck with your work.
Thank you. Thank you so much.
And thanks to everyone who joined us today for Ask the Oncology Expert.